One of the things that's a big criticism back in the States, and I'm sure it's true here, is that there's all these hard copy forms. This is 2017. Everything in our country is moving to electronic medical records, EMRs. And so in my country, there's over 1,000 different companies trying to peddle different EMRs. It's a very competitive market. And so different technology, different software, it's a kind of a mess. The thing that I've sort of bet my stake on is using a Microsoft Surface. I'm not getting a kickback from Microsoft, but basically a Surface, you can actually completely recreate the hard copy experience. You write with a stylus, you hit an icon, it autocorrects, including spelling. You hit another icon, whoosh, all the data goes into the EMR. It's still about 6 months away from being something we can readily do, but it perfectly replicates. And here's the thing. We did a study. Typing and writing are different activities. Did you know this? And writing is superior. And I'm not saying, I'm middle-aged and all that, but I'm not saying this with a bias. We encode differently, we retrieve differently, and remember differently from writing versus typing. And writing is superior. So this way, with this technology, you can have our cake and eat it too. So people really hassle me about this all the time, and I just say it's in progress. We're not gonna march it down the field and then spike the ball before we get to the end zone. That's an American football metaphor. We've got to get it right. You don't just flip this into a technology without really studying it thoroughly. And from an internal validity standpoint, it's really important to have a technology that sort of is consistent with the model. So this is what I've been sort of critiquing all morning, the idea that the therapist is in a superior position to the patient, that the patient is conceived as a depressed person with a symptom of suicide, and where the model that I grew up with, which was hospitalizing every suicidal person, treating the disorder, and using no-harm contracts, is basically a busted model. And the worst part about it is that it puts the clinician in the power position over the patient, which means that they're going to oftentimes be invalidating, coercive, intimidating, and do things that patients don't necessarily want to do. So I'm the expert, he's the patient, he's passive, I'm active, I'm treating him, he's a recipient of my brilliant care. That's the dynamic that we're trying to defeat. Because when we take a seat next to the patient with permission, it's a very symbolic and meaningful thing. Because what we're saying is, I'm not above you, I am a collaborator with you. Now, when I first was doing this in Denmark, and I was showing these videos, the Danes, and I'm sure that, are the Danes like the Norwegians? They were like, you're too close. And I was watching these Danish videos, and the clinician was like, so, cultures have different levels of closeness, but the idea of being on the same side is the important part. And then, we look at suicide as the bullseye, not as a symptom, but as the bullseye from the patient's perspective. Depression may be on board, maybe what makes them suicidal, but then the question is, what makes you depressed? And it may be your biology. So, okay, so we'll give you medication. But usually people have reasons for being depressed as well, so we can treat those things. So the goal of CAMS is to keep somebody out of suicide, to understand the functional utility of suicide, because we really want to know for this person, how does being suicidal work for them? Well, I mean, work for them, what function does it serve? What sustains it? How are they alive with suicide, if that makes sense? And so we can understand it from that perspective. In this regard, the patient is a co-author of their own treatment plan. So this creates a very different kind of picture. Now, you think this field should be more evolved than it is. It's shocking. In 1995, I published a paper where we took a small, it was actually an early paper, but we did a couple of papers looking at a cohort of patients in treatment and what their outcomes were. And this was like a really big deal. And I'm not saying that to be immodest. That we would actually watch to look at treatment outcomes with a cohort in treatment. In 1995, that was like a publishable thing. It's just so unevolved when you think about it. That some people respond to treatment, that some people drop out of treatment, that some people are chronic and some people go to the hospital. That was actually, a sort of a cutting edge kind of thing. But then from these models, we can develop different theoretical approaches and think about sort of, the idea that, not all patients get the same treatment. That there's different kinds of suicidal states in need of different kinds of treatment. In 1995, that was a radical, radical notion. We have both this quantitative and qualitative aspect to the SSF. So this core SSF, we've studied the daylights out of it. So it's psychometrically valid, it's reliable, the variables do not co-vary, so a big threat for you statisticians out there who do test construction is multiclinearity, that variables just co-vary with each other and don't really describe different parts of variance. These variables tend to not be overlapping, they tend to be quasi-independent, and they describe, in factor analysis, they describe different kinds of suicidal states. And then there's all this stuff that people write, and this is a patient, is writing. I mean, they write really important, provocative, and, that reason for living is my dog, and the reason for dying is I'm fat. I mean, people will tell you, when given the chance, sort of what's on board for them. And we've done a bunch of studies with these kinds of responses. So the SSF core assessment has been sort of the bedrock. It's administered every time the patient comes in, right up to the final session. We published a counseling center paper that showed that these variables describe, are you familiar with the metaphor of the blind people and the elephant? Each are arrayed around the elephant. Each is describing a different part of the elephant. And each is describing a valid, true aspect, but no one perception is describing the whole animal. That's a great metaphor for what you want a psychological tool to do. You want to describe as much of the elephant with as few variables as possible and not repeating yourself. So the person at the tusk is describing a very hard, smooth part of the elephant. The person at the tail is describing the elephant tail, whatever that feels like. Each is describing a different part. In this study, we described about 30% of the elephant with these 6 variables. 30% for a factor analysis is not that bad. But it was college students, and they were Catholic University counseling students, so they were 85% white Catholics, and that doesn't generalize very much. So a very legitimate critique of the psychometrics in this sample was the sample, that it was college students who were mostly white and Catholic. But then we went to the Mayo Clinic and did a replication study, a much more rigorous study, and it described 72% of the elephant in the factor analysis here. So it worked fine with college students. It works much better with high-risk inpatients. Again, valid and reliable, very rigorous replication study. So we really feel like the core assessment is rock solid from a psychometric standpoint. Great data across the board here. And then, people describe these different reasons for living. So family scared of the unknown, reasons for dying, hopelessness, anxiety attacks, relationship problems, weight, money, job issues. We've we've developed reliable coding systems. Our reliabilities now are like 0.99. We've gotten so good at coding these data. And suicidal people can describe lots of things that keep them going. But what's really interesting about reasons for dying is that they oftentimes, in non-attempting samples, in ideating samples, it's very escape-focused. We have an attempter sample from Beck's lab that's very self-focused. So different samples give different kinds of responses. We got to get that paper published because it's so interesting. This is a counseling center sample, a lot of college students, and describing their reasons for living, plans and family, enjoyable things. At Johns Hopkins in the counseling center, we had 5 different students one year describe The Simpsons as a reason for living. Do you guys have the cartoon show The Simpsons? That gets coded to the enjoyable thing. I hope it's not your reason for living, but if it is, so be it. And then with the college sample, they're very focused on self and escape. In our military samples, perhaps not surprisingly, escape is predominant. They live in a command structure. They're not loving military life. They can't readily get out. They feel trapped. Mark Williams has taught us about entrapment, psychological entrapment, as being a sort of a key feature suicidal states, and we tend to see that in their responses. Now, one of the reasons that we do this kind of research is that you can take a big sample of college students and look at their reasons for living. This is a counseling center sample. And then because I live at a university, we can also recruit a non-suicidal sample out of our intro psych courses. Do you guys do this here? Use intro psychology courses to recruit students for research? Do you do that? Human subjects pools? It's really handy. It doesn't generalize to anybody, but they're, you can use them. But here it actually matters because our clinical sample had their reasons for living, and our non-clinical sample is asked the same exact question. They have more responses. Now that might be an artifact of doing this for course credit versus being in a clinic and freaking out. But they have more reasons for living, responses, and there's a lot of significant differences. For the suicidal sample, their reasons for living, percentage-wise, are more focused on family and the idea that their suicide will burden their loved ones, will stigmatize. Sort of the opposite Joiner's notion. But look at this. For the non-suicidal sample, their reasons for living focus on plans and goals, hope for the future, and beliefs. It's much more aspirational. In fact, look at the percentages. Within subjects, plans and goals is the #1 response, but when you compare them to a non-suicidal sample, they have twice as many plans and goals, reasons for living. This is generally referred to as a protective factor. That if you have more plans and goals and hope for the future, and if I'm Catholic and my faith helps me get through, that keeps me afloat. Right? I believe that even though I'm going through a difficult time, it's going to get better. It's not that these guys don't have it; they just have so much less of that, and maybe that increases their risk. Right? So this is why control groups are really handy. This is a paper I love. Ray Tucker is the lead author, looking at risk factors and then warning signs and drivers. One of the reasons I love this is that I'm not an author, and I mean that in a non-provocative way. I love that the field is kind of grappling with this because risk factors are, in my view, very limited in their value. Joe Franklin's meta-analysis sort of put a nail in that coffin. They don't predict more than chance. 50 years of risk factor research that has dominated our literature does very little for us, right, Heidi? Russ, thank you. But are obsessed with risk factors. Warning signs are an interesting thing because they actually sort of borrowed this notion from heart disease, cardiac illness, getting into some approximate near-term risk, right? So lots of people walk around with risk factors for heart disease, obesity, diabetes, hypertension, smoking, but they don't die of a heart attack. But if they have radial pain in the arm and chest pains and faintness and shortness of breath, then they're experiencing warning signs of a possible myocardial infarction. So warning signs is a nice, interesting model, and a lot of our warning signs tend to focus on dysregulation, agitation, anxiety, a clear plan, a clear access to means, or things that are much more in the near term increasing the risk. Drivers then, from the CAMS model, are personalized warning signs, right? Because what may be my driver compared to Heidi's driver compared to Roar's driver, is unique to us. It's the straw that breaks the camel's back, so to speak. But it's my straw, right? So the idea is we've got, thousands of risk factors. Warning signs sort of shortens up the list. Drivers really shortens up the list and makes it specific to that person. So I love this paper because it kind of helps us think of the evolution of that model. So self-hate, past trauma, these are very common in our samples. So adherence to the model is actually pretty straightforward. There's kind of a philosophy you've been hearing about directly or indirectly of empathy, no shame, no blame, collaboration, honesty and transparency. And then there's this framework. We focus on suicide, it's outpatient oriented, and we're agnostic. And we focus on drivers. When I first thought about doing clinical trials, I hate manualized treatments because they feel too rigid. And I'm so brilliant, I want to do it the way I want to do it. So following a manual, it never clicked for me. Although I respect it, and the data speaks for itself. I like the idea of a framework, and then Greg Brown said, well, you still have to like study adherence. And I was like, well, how do you adhere to the framework? He said, well, you get them to be adherent to domains. So adherent to collaborative assessment, adherent to collaborative treatment planning, adherent to understanding the patient's suicidal drivers, being problem-focused in their interventions that focus on drivers, and the final phase is reasons for living and purpose and meaning. And these are very broad-based ideas that we can actually watch videos and say, yep, they're collaboratively assessing. They're taking a seat next to the patient, they're collaborative treatment planning, they're not talking over the patient or telling the patient what their drivers are. And you can actually watch videos very readily and evaluate that. So this is what a case looks like first session. This is a former veteran. I kind of want to get to the data here in a minute. A really important thing about CAMS, and our stabilization planning is different than Barbara and Greg's because means restriction is the sixth item on the safety plan. On the stabilization plan, it's number one. Because to me, in CAMS, if we're going to stabilize you and keep you out of the hospital, and you've got a gun in the house, we got to find a way to get the gun out of the house. In my practice, I keep gun locks. I keep cable gun locks. And if I feel comfortable with this patient and the concept, they'll take the cable gun lock home. I'll keep the key. They lock their gun up. They take a picture on their smartphone, and they text it to me to verify that the gun's been secured. So there's all kinds of creative ways of thinking about means restriction. And it's really important because when you don't, it can be very costly. I'm in the lab. I'm watching a video from our Army trial. This very good clinician is working with this borderline female patient who's talking about a stash of pills, and I'm watching, and I'm watching, and I'm watching, and I'm watching. And typically he would say, well, we got to secure your stash of pills. And I don't know if he's having a bad day or just being lazy or running out of time, but he didn't secure those pills. And so I get to the end of the video, and I pick up my cell phone, and I call Brad. I said, Brad, what the hell? The session I just watched, she's got that stash of pills. You call her and get her to bring in the pills. It's like, oh, I don't think she's got it. You call her. She cannot go back to the barracks with that big stash of pills. It's like, okay. So later that day, I'm at my son's football game. I'm sitting in the stands. I get this text. It's from Brad. That's her stash of pills. I practically fell out the stands. Right here, that's enough to kill her 3 times over. This is called polypharmacy. This is too much medication for one person, too much lethal ways of killing herself. And when she brought these pills in and poured them out on his desk and lined them up, as you see here, she stepped back and went, She was relieved to not have this competing with her treatment. Means restriction is really, really important. In my country, it's all about guns. That's our number one for men and women. More documentation. Here's the interim. So every time the client comes in, boom, 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 takes about 30, 40 seconds. What's really cool is that the client starts to learn the language. And they'll come in and say, oh yeah, I had a really tough week. My self-hate kind of spiked, but my hopelessness is down. We had it's great. We had a soldier at Fort Stewart who would, take the forms and go home and put them on the refrigerator and call his wife over and go over the form for the week and his treatment plan and talk about his stabilization plan, right? And go over that each week with his wife. So, I love the operationalization of the tool. And every session then ends with a treatment plan update. And here's your documentation. So, we treat drivers. And we can steal from everybody or anybody. You can actually do your own things that work. These are just examples in the literature of things that I use all the time to treat drivers. We also really feel in agreement with Marcia that, it's not enough just to cope and somehow survive, that if you're going to really carry the day in the suicide business and treatment, the patient actually has to want to live their life. And that's no small undertaking. But it really does, at the back end of CAMS, require a big focus on thinking and future planning, short and long-term goals, hope for the future, developing a life worth living. This is kind of when I meet with the group tomorrow, a big focus of where our research is going is sort of like outcomes and how do you live a post-suicidal life? Especially if you lived with suicide for a long time. How do you embrace a post-suicidal life? Okay, so we have overall risk less than 3 for 3 weeks, no past suicidal behaviors, effective management of thoughts and feelings. All right. Outcome, disposition. You're done with CAMS. Oh, I worked so hard on the slide. That's a mess. Basically, 8 correlational studies showing that CAMS has been effective. 2 with non-randomized control groups at the Air Force, 3, and 2 inpatient studies with Tom Ellis at the Menninger Clinic. 2 Danish studies, the Arco study and the Nielsen study, 2 counseling center studies. So we've got lots of, I'm sorry the table's such a mess, but we've got lots of data that's consistently showing the same findings. But we can't say that CAMS causes these findings because it's not a randomized controlled trial. But the correlational data look really nice because you get data that looks like this. That you see rapid reductions in ideation. This is the Air Force study that we published a long time ago. That would otherwise take 25 to 27 sessions. And what's been interesting is in our more recent studies, this is coming down now not in 10 to 12 sessions, but 6 to 8. So as we get better at developing CAMS, it seems like that we're pulling this big bar in, with 6 to 8 being the modal response to CAMS. And this was a very exciting finding because we saw differences in behavior around visits to the emergency department and to primary care appointments. And then you can cost this out, and this is like $6,000 to $8,000 of cost savings if CAMS was effective. So it's a correlational finding. We're obsessed with replicating it because it's money. And it's an example of a mental health intervention saving big dollars, because these are expensive dollars. These are expensive dollars of non-mental health care utilization. For those of you who are fans of meta-analyses, this is a meta-analysis that included our Air Force study, among other different studies of psychological assessments that function as a therapeutic assessment. And we've got a nice little effect size in there. And this is just another way of proving something works. A meta-analysis is a big study of lots of studies, and CAMS lives in the world of therapeutic assessments. That is, for assessments of anxiety, depression, different kinds of obsessional thinking. These are 17 different studies, and this is the single suicide study, and the SSF has basically this effect. So that's good. This is a non-significant finding and disappointing, frankly. The inpatient use of CAMS at the Menninger Clinic, where we showed an effect. This control group was created by a technique called propensity score matching, which is a statistical way of creating a control group. You match on certain key variables. But the Menninger sample after discharge were immediately going back to the hospital, where we delayed it by 5 sessions, but it was non-significant, even though it looks pretty meaningful. And attempts for 5, this is a really high-risk period post-discharge. So we were pleased to get out to 5 weeks, but we were hoping to get out to 2 years, but it's hard. Oh, God. I spent like 2 hours on this slide. What a mess. Well, we'll just go over here. We've published now 3 RCTs. There are 3 RCTs of CAMS. The NDA study, Kate Andreasen. Kate was the colleague that was supposed to be here this afternoon, but was not able to make it. So I'll talk a little bit about that study, comparing CAMS with DBT. This is in press now with Fort Stewart. This is a new study with Jackie Pistorello with college students. Here's our friend here, Roar Fossey, and his team looking at CAMS against treatment as usual. This is a current ongoing study, and there's a new study in Germany. Miriam Santal, who I've just been emailing over the years, has started this up back in May. So lots of RCTs underway and in different stages. So this is called the Next Day Appointment Study. Actually, it's a pretty small study with basically 32 patients randomized to CAMS versus enhanced care as usual. with 20 patients at the end of the trial. It's significantly underpowered to find significant findings, and yet everything was significant in support of CAMS. Ideation, this is 2, 4, 6, and 12 months follow-up. Here's treatment as usual. Big difference here. Reasons for living, overall symptom distress, and increased hope. So that doesn't get you into empirical validation, but it's a good step in the right direction. But you need more replication, you need independent research. But we found significantly higher patient ratings for satisfaction in CAMS versus treatment as usual and better clinical retention. So that's a foothold. Then Mette Nordentoft's group did this DS study. This was Kate Andreasen's dissertation. Kate's a psychiatrist working with Mette, and they are experts in DBT. And we have a close colleague, Bent Rosenbaum in Copenhagen, who's been a champion of CAMS. Mette asked me if I'd be willing to do this for 154 borderline personality disorder patients who made recent attempts. DBT is like built for this exact population, but they wanted an active control group. So I thought, well, you know, what the hell. But DBT should have absolutely buried CAMS because it's just built to treat this population. Really, really hard study. They ran out of time and money. There were various recruitment issues. They were only able to ultimately recruit 108 out of the 154, so it was an underpowered study. And much to my amazement, CAMS and DBT did equally well. No statistically significant difference between CAMS and DBT for self-harm and attempts, but it's looking pretty good for CAMS. But it's not statistically significant because it's underpowered. So it's trendy and encouraging because we never thought that we could even compete with DBT. There are some methodological challenges with this study, but they were earnest and really worked hard, and there's a lot that's right about this study. It's just disappointing that it was a little bit underpowered, especially with data looking like this. This is an unpublished thesis of Bent's student of patients in the CAMS arm of the trial only. So it's a within subjects sample of only 20 of the 58 patients. So in other words, 38%. 38% of the patients in the DS study did ridiculously well with CAMS. And I'm not even trying to be immodest. They got 6 to 8 sessions of CAMS, and a year follow-up, the effect sizes are wildly robust for borderline personality disorder, for depression, 2 different measures of depression, hopelessness, suicidal ideation, not for impulsivity, but for self-esteem and for anger. It's astonishing to me that they did this well. In the DBT arm of the trial, they got twice a week DBT for 16 weeks. So they got a ton more DBT than the CAMS group got CAMS. So I don't know what to do with this because we don't think of CAMS as a treatment for borderline attempters. We think of DBT as a treatment for borderline attempters. But you'll see more about that in a second. This is the Operation Worth Living study, $3.4 million in 6 years of my life to do a randomized controlled trial with highly deployed Army soldiers at Fort Stewart in Georgia. 3 months of CAMS and 3 months of control enhanced care as usual with measures at 1, 3, 6, and 12 months. We had almost 80% retained at 12-month follow-up, which is spectacular, I must say. These are the clinicians doing CAMS, watching them on videos, and these are the control clinicians not doing CAMS, watching them on videos. So this is called fidelity. So we have superb fidelity checks with high inter-array reliability. And this is the CAMS rating scale that we use when we watch the videos. And the takeaway is everybody got better. Everybody got better. So that from a humanitarian standpoint, that's good news. From a scientific standpoint, it's desperately disappointing because you want to see the group that you're studying do better and this one not do quite as well. The only significant finding was at 3 months where CAMS eliminated suicidal ideation, but the effect went away at 6 and 12 months. The data almost all look like this, where both treatments were equally effective. That said, I've never presented these data before, so this is brand new data. There are moderator analyses that are highly supportive of CAMS. So among married participants, we saw a significant effect for overall functional impairment in the CAMS arm. So moderator analyses break out groups and identify certain variables that are, in this case, in favor of CAMS. There was a similar finding for symptom distress and people who had low baseline distress. There are findings, this probably is, in terms of age, that older soldiers have more of an effect on ED admissions. That being married was more protective in the CAMS arm. That deployments actually favored control group, but that being the first 4 years of service favored the CAMS arm. So moderator analyses are meaningful, and in all, except for the deployments, all of this favors CAMS in a statistically significant way. This is a clinical trial that's called a SMART design. It's called SMART because it's a sequential multiple assignment randomized trial. Sequential multiple assignment randomized trial. We took college students who were randomly assigned to CAMS or treatment as usual for 6 to 8 sessions and then saw how they did. That's stage 1. About 50% of them responded in 6 to 8 sessions. That's really good news. The other 50% didn't. So CAMS easily picks off half the sample in 6 to 8 sessions. For those that didn't respond, there's a stage 2 randomization to now 16 weeks of CAMS or 16 weeks of DBT. Or if they were in the control arm, 16 weeks of CAMS for the first time or 16 weeks of DBT. What's really cool about this is that you can do between, within, sequencing, different dosing, different types of treatment for different kinds of suicidal people. So this does get to this idea of prescriptive treatment. And what we found overall was that CAMS really sort of captured the low-hanging fruit of upstream ideators, but for those who are chronically, multiply attempting, more distressed at admission, they did not respond they responded, but not as well as CAMS as they did treatment as usual, and they're probably good candidates for DBT. I mean, exactly the people that we think would be good for DBT. The problem is with a small feasibility study like this, there were only 8 patients that we were able to push out to this level. But we had enough in stage 1 to actually get some pretty interesting findings. CAMS was significantly effective for suicide, ideation, depression, and anxiety. And here's the punchline. These are the same clinicians. It's just that here they're using CAMS and here they do what they normally would do. We've got great fidelity data to prove it. So that's really good because they're serving as their own control. And to get such nice data with the same clinicians really sort of isolates the effectiveness of CAMS. So we just wrote an R01, a big grant, to study 700 college students across 4 universities, $12 million grant. Let's see if you get it. That's how much you need to actually flush out and complete the SMART, to actually get enough people in these cells. You need 700 students and $12 million to do it. We'll see if we get it. But if it gets funded, it'd be the largest college student study in the world. And I love these SMART designs because I really do believe that DBT is fantastic, but not for everybody. And we now have data from the Army study and the Reno study that says multiple attempters, chronically suicidal, borderline patients probably are better candidates for DBT, where CAMS handles all the rest, or most of the rest, I would say, except for that 38% in that Copenhagen study, which I don't know what to do about. Okay. This is the Aftercare focus study. This is a very, very, very tough study, of the hardest study we've ever done. These are patients coming out of the hospital having made a suicide attempt. It's kicking our ass. What can I say? I mean, this is the hardest patients that I've ever seen. We've had 1 completion. We've had a half dozen attempts. I think we're hitting the ceiling of what CAMS can do. But we knew this is a very high-risk patient population because they're coming out of the hospital. And there's lots of data, Marete's data in Denmark, others, showing that the weeks post-discharge are extraordinarily high risk. 300, 400, 600-fold increase of risk in the weeks and months following hospitalization. Michael Bostwick showed that 1 hospitalization increases lifetime risk for completing suicide forever. Again, I'm not saying this to bash hospitalization, so you might work in a hospital, but the question is, what are we doing with these hospitalizations, and are they actually suicide-specific enough? We are tailoring CAMS for teens and young children. We are running a R34 for kids under the age of 12 to do an RCT. We have 2 different clinical trials in the works with teenagers. I can say more about that, but I want to kind of press on. Here's the thing about training. Didactic training doesn't change clinician behavior. It just doesn't. You can be a brilliant trainer, and people can love what you do. I spent 6 months of my life on sabbatical plowing through Georgia, Alabama, South Carolina at 9 different VA medical centers. I trained 165 clinicians. It was the highest rated training in that year in the VA. I'm not saying this to brag, I'm just saying it was really good training. People loved the training. Really high ratings across the board. We studied it, and I went back a year later, and only 10 people were doing the intervention. I'm sure you're shocked to hear that. This is the problem, that we don't mind being trained and talked at, and we can check our texts and things like that, but we don't change our behavior. Do you know what changes clinician behavior? Anybody know? That's scary. Anxiety? Yeah. No, that can be motivating. I'm talking about how do you actually change clinician behavior to actually do something that works? Feedback. In what form? Corrective feedback, like in a coaching call? Oh, during training. By role-playing? Yeah, okay. Role-playing works, right? So we're all going to role-play. No, we're not. Role-playing changes clinician behavior, and coaching calls after the role-playing sustains it. Clinicians hate role-playing, and they don't like these calls. So it's a big problem. So my wife and I formed a company to get clinicians to change their behavior. We've got an integrated training model, which is a 3-hour online training that you're welcome to sign up and take, plus a day of live role-playing, plus 6 to 8 coaching calls. And that changes clinician behaviors, and we're studying the daylights out of it. So we're trying to get the least amount of training for the maximum amount of impact. By didactic training, this does not work. So it's really a challenge, but we're after it, and we're studying it. We went to an outpatient clinic in Columbus, Ohio, that had a very high suicide problem. They'd had a bunch of completions, and they were sort of on notice. And I won't belabor this, but what was great about this is that it was a systems-level intervention. This is called a CBOC, and I can't remember what the acronym stands for, but an outpatient clinic for veterans in Columbus, Ohio. And this is sort of their existing model. And then we came in, and this was their evolved model. And we did training in the CAMS model, and they initiated it. And the correlational outcome data are just stunning. Their hospitalizations dropped. Their attempts dropped. Their involuntary, look at this, involuntary hospitalizations were eliminated. We did the training midway through 2014. Their high-risk list came down significantly. Their code oranges, which are psychiatric emergencies, also dropped. So, I mean, this is data that you love to see if you're a clinic director, where there's actually changes in outcomes that seems to be highly related to this intervention that we brought in. And the thing I like about it is not only were they doing CAMS, but they had a systems culture change that accommodated the intervention, which meant that they were hospitalizing less, they were working collaboratively, they were making that kind of difference. Almost to the end. So, technology is hot. I thought I'd let you know that. Technology is really big, and it's coming your way. Here's the thing. Relational agents are a very interesting thing, avatars. And they're increasingly being used in mental health care. And what relational agents can do is actually elicit more responding in patients, especially around shameful topics, than actual living clinicians. This was a Boston University study so brilliant because patients on medical surgical units, especially older people, don't follow their discharge orders. They don't change their dressings. They don't refill their scripts. They don't do what they're supposed to do. What happens? They're right back in the hospital. It's a chronic problem. It's really expensive. So these guys developed a Nurse Louise based on the actual discharge nurse, and basically had her give the discharge orders on a tablet, and they did a randomized control trial. And it turns out that Nurse Louise led to a 30% reduction in repeat hospitalizations and all kinds of improvements in comparison to the actual living nurses. And then the funniest thing was they did focus groups, and people were like, oh, I love Nurse Louise. She was so understanding and so non-judgmental, and she was never burned out. And she had all the time in the world for me. And just really nice things about this avatar. So it turns out that now in substance abuse, avatars are being used, and people disclose more about their substance abuse into an avatar than they would to a clinician. So one summer afternoon, I got a call from Kelly Kerner, who's a researcher out in Seattle. And Kelly was reading up on this, and she and we're buddies, and she said, how long does this typical suicidal person sit in the emergency department waiting to be seen by the doctor? I said, a pretty long time, right? They get triaged over. It's a pretty usually negative experience. If they're a smoker, they go through withdrawal. I mean, the ED experience for most suicidal people is not a positive one. There's a literature on this. It's usually, 4, 5, 6 hours, 8 hours. Even in psych EDs, people still wait hours on end. And it's a pretty negative experience, right? She said, yeah, well, how about if we developed an avatar intervention that they could do while they're waiting to see the doctor? And I said, that is a clever idea, Kelly. What a great idea. And she told me about this research, and I looked at the paper. I said, that's fantastic. And she said, yeah, and we were thinking, how about you being the avatar? And I said, whoa, I'm in. I think it's a great idea. I have no idea what you're talking about, but it sounds really interesting. And so we developed an avatar of Dr. Dave doing a very modified version of CAMS. Now, my wife hates this avatar, but this was the fourth generation where I didn't look like I was a burn victim unit. I mean, but here is the thing. We did a feasibility study with this with 62 people. Only one person didn't like it. Everybody else loved it. They can engage with me for as long as they like. They can also engage in coping skills. There's also videos of peer bridgers telling their stories of being suicidal, basically lived experience folks, that can give them inspiration. And we can then do in this interactive way. It's not like my kids like Call of Duty, like video games, because those games cost millions of dollars. We didn't have that much money, so my eyes blink and my mouth moves, but basically I don't change position. That takes a lot of money to build a more sophisticated avatar. But if we get the next grant, we're going to build a more sophisticated version of me. But we can ask these questions, and we can gather the data, and then that data populates a report that is informed by all the research we've done that I've been describing to you, that walks the clinician, when they finally show up for the patient, through a lot of key things that may really help them in their deciding the disposition of this patient, to perhaps not hospitalize them. But if they're not going to hospitalize them in the next phase of this grant, they're going to get a suite of apps that Matt Nock developed at Harvard on their phone. They're going to have the option for electronic momentary assessments, and they're going to get a bunch of apps that are self-help apps that are specific to suicide as they leave the ED. And they're going to get non-demand follow-up care and contact from Dr. Dave. Automated emails, automated voicemails, and automated texts. They can pick whatever they want. So it's really interesting. And again, this is a really big grant, but I think we're going to get funded because we have just an amazing team. And nobody says, oh, the ED experience is not that bad. No one says that. Everybody knows it's terrible to sit there for 2, 4, 5, 6 hours in a highly distressed suicidal state waiting to see the doctor, right? So at least for 3 or 4 hours, they can do this. And the clinician's going to get a lot of information when they now do their evaluation. So CAMS is evolving. The first edition of the book sold 13,000 copies. That's good, but not much when you think about all the clinicians in the world and all the suicidal people. It was very assessment heavy. So like the Danish version of CAMS is sort of this version. It's very much focused on the SSF as an assessment tool, not so much as an intervention. The second edition of the book, which came out in August a year ago, is very much intervention and treatment focused, and based on the clinical trials and based on this driver-oriented treatment. And I've got one more in me that's going to be focused on outcomes and sort of what we've learned from the clinical trials in the back end of things. So, and then I'll hang it up. I'll call it a day. That'll be my career. I want to say one more thing. I got 2 minutes. I want to say one thing about the effective treatments. Actually, I'm going to go 3 minutes too long. Is that okay? Okay. I can get back my 3 minutes from that first break. Okay. So basically, this is what we've got going on upstairs. And basically what we know from the neuroscience of this is that this mammalia part of the brain that my dog has and that all mammals have is in all of us. And what makes us super, super special as Homo sapiens is this massive cortex, right? That sort of surrounds, the more primal part of the brain. The amygdala is the troublemaker. And the hypothalamus is supposed to control the amygdala, but sometimes it breaks, it sort of doesn't do the job. And when the amygdala gets overactivated, this limbic system gets highly activated. And then what happens to the frontal lobes? Does anybody know? When the limbic system gets activated? Anybody know? Shuts off, right? So this executive functioning, insight-oriented quarterback of the mind, the most important part of who we are, what we got, shuts down. So what I would contend is that in DBT, in BCBT, and in CAMS, what you have is a process whereby we're finding ways of turning this back on, right? So when you think of chain analysis in DBT, this behavior doesn't just happen. There's a whole bunch of steps in the chain that get you to this behavior. And the chain analysis helps the patient learn about how they get in trouble. The suicidal mode, same thing. And in the CTSP and BCBT model, they always draw this out on a whiteboard for the patient to see that there are certain predispositions and triggers that activate the mode that has cognition and physiology and behavior and emotions. And this mode is highly interactive. And when it's turned on, this part of the brain's turned off. So when they learn about their triggers or when they get in these highly suicidal states, they're then learning about interventions and coping strategies that they can do that then re-engages this part of the brain to down-regulate this dysregulated limbic system. And, obviously, we have all these documents and forms and all these things that help re-engage that part of the brain. And here's the thing. In the research, the neuroscience research of mindfulness, there is growing evidence that this ventral medial prefrontal cortex, this very special part of the brain back here, is sort of where the seat of really important things like mirror neurons. And mirror neurons are really, really special. As therapists, we need them. As people that suffer and struggle, they need them. But mirror neurons are at the heart of perspective and empathy, including empathy of the self. So one of the things that we're hypothesizing is that effective psychological treatments actually stimulate these parts of the brain and activate the part of the brain that helps give perspective. It's why I love mentalization so much. Because mentalization, the Bateman and Fonagy's model, is this idea of looking at yourself from the outside and looking at others from the inside. It's that lack of perspective that is endemic in depressive states and in highly suicidal states. And these psychological treatments basically get that perspective back, or maybe discovered for the first time, and there's got to be a neurological correlate. Now, the thing we'd love to do is stick a highly suicidal person in the magnet, take a picture of their brain, give them treatment, and then put them back in the magnet. That's like a $6 million study and really hard to do. And if you've ever been in a magnet, it's really hard to tolerate those things. So, we think that's what would happen with the effective treatments that I've described to you this morning. This is my final slide. essentially, this is a model that I first presented here in Oslo. Lars Mellem had me come to do a plenary session about the future of care for suicidal risk. And, to be frank, to me, at least in my world, it's all about the money. I mean, of course we want to save lives, but the tail that wags the dog of what actually happens in our systems is so much driven by the money. And so we have a model where, crisis center support has grown. And since our election in November, calls to our National Lifeline have gone up 31% and have stayed at 31% up. You can interpret that as you wish. And we have brief interventions and follow-up, and we have outpatient care, and we now are seeing the emergence of respite care centers and a resurgence in partial hospitalization and a reduction in inpatient care. And the thing is, we have a need for a much larger workforce. And if the other candidate had been elected, one of her signature features was going to be a mental health agenda, and we already had a mental health core sort of plan, like a Peace Corps level plan on the drawing board, but that didn't happen. But we do have evidence-based interventions that I've described to varying extent to you, and of course CAMS does everything, that can layer in to all these layers of the intervention for my country, the 9.8 million Americans that suffer with suicidal thoughts each year. 9.8 million Americans each year. But we need so much more, and this starts to get us there. Anyhow, remember this guy? This was not his day to die, because this gentleman knows what he's doing. His name is Kevin Briggs, and this man is Kevin Berthea. And Kevin Berthea is giving Kevin Briggs an award 20 years later for his work in suicide prevention. He was a CHIPS highway patrolman whose beat was the Golden Gate Bridge. And by estimations, the best I can do this, they estimate that over 300 people he helped climb back over the bridge. And 20 of them plunged to their death. Kevin's a friend of mine, and he said, what's interesting about this picture? He said, I don't love this. I said, I love this picture, but the original picture of him looking down, he said, I have a problem with that, because what I mostly did was that a lot of these people sit in this bar, and he said I would lie down on the pavement to be at their level. He said, was I doing CAMS? It's like, yeah, that's CAMS. Sure, Kevin. You're a genius. I'd be happy to be associated with you. In all seriousness, I love that notion. Without any mental health training, this man has helped save 300 plus lives. He's just a good person. He's just a good person who knows how to connect with people. You know how this conversation started? He got the guy's first name. He said, "You're Kevin, I'm Kevin." And they talked about being Kevin for like 10 or 15 minutes. It was just that little hook. Just that little hook that made the difference. This was not his day to die. Today, this man is gainfully employed. He's actually on the road. These guys are buddies now. He's on the road doing inspirational talks, as is Kevin Briggs. And they are, he's married, he's got 2 little kids. This is a great outcome story. We are uniquely positioned to save lives. And what it comes down to is you've got to be a human being who listens and really is open to the experience of the suicidal person. And when you do that, it's very validating to their experience. And most of the people that are talking to us in our clinics who are suicidal don't want to be dead. Otherwise, they'd be dead. So they need a different kind of response. CAMS is one version of it. And maybe there are others out there that I don't know about. But really, folks, these are people who are needing to be saved. And we're the ones in our culture and society to do it. So that's my lab group, at least last year. We got to give you pictures. This is my email, jobs@cua.edu. We're on Twitter. I'm actually on Twitter. It used to be my students just did it, but now I'm on Twitter. So you're welcome to check us out there. And I really appreciate you coming today. Thanks.